Hello everyone, hope you're all doing good. In this video, we are going to discuss about shoulder dystocia. See, shoulder dystocia is a mechanical problem that is happening during normal vaginal delivery, and it is characterized by one of the following I am going to mention, right? So, first one is there is failure to deliver fetal shoulders using gentle downward traction. Okay. So, what we will be doing is first the head will be delivered and then we have to try to deliver the shoulders. While delivering the shoulders, if there is a minor problem, we can assist in delivering the shoulders by giving a downward traction. But even with a gentle traction, it is not possible to deliver the shoulders, right? And because of that, there is a requirement of additional delivery maneuvers to deliver the baby finally. Okay. So, how do you diagnose this? See, you diagnose this when there is a documented head to body delivery ratio of more than 1 minute or 60 seconds. Clear? So, the head has delivered. Because the head is going to be the largest part of the fetus, as soon as the head is delivered, there should be no difficulty in delivering the rest of the body, right? But here, what is going to happen is, only the head comes out and rest of the body is going to get stuck inside, okay? And the delivery timing crosses more than 1 minute. So, that is shoulder dystocia. Clear? So, this is how it is going to be. See, if you show this pic, you are able to see only the fetal head has come out and the rest of the body is stuck inside the maternal body itself. Okay, just like how the turtle is showing the head alone and hiding the whole of its body under its shell. Okay, and this is called as turtle sign. So, if you properly define turtle sign, it is nothing but the retraction of the fetal head towards the perineum. Okay. So, that is turtle sign. This is specifically seen in shoulder dystocia. Clear? And also remember that shoulder dystocia complicates around 0.6 to 1.4% of vaginal deliveries. Clear? Yes. Now, we will see the etiology. Okay. Why does shoulder dystocia happen? Etiology of shoulder dystocia. We will see the maternal causes first. There can be pre-gestational or gestational diabetes, okay, or there is a previous history of shoulder dystocia, or a history of operative vaginal delivery, or history of maternal weight gain, okay, increased maternal weight gain, or there is a history of maternal obesity itself, that is pre-pregnancy obesity, or there can be labor dysfunction. Okay. See, all these risk factors are going to show one common thing, that is they are going to lead to fetal macrosomia, and because of that there can be chances of shoulder dystocia. But all these risk factors are of a poor predictive value. Okay, that means one risk factor is present means it is not always that the baby will be having shoulder dystocia. Correct? Yes. So, we will see the consequences. What are the problems that will be faced by the mother as well as the baby. Okay. So, for the mother, there is a risk of postpartum hemorrhage, or third or fourth degree lacerations, And for the fetus, there is risk of brachial plexus injury, brachial plexus injuries, or there can be chances of bone fractures also, like the clavicle or the humor fracture, or sometimes because if they get stuck inside for a long time, there can be chance of hypoxic ischemic encephalopathy as well as fetal death. Okay. But if we attempt a good delivery maneuver and if we deliver the baby, this both can be transient. Okay. They will usually recover. Clear? Yes. See, shoulder dystocia is an obstetric emergency. So, whenever you are diagnosing shoulder dystocia, what you have to do is you have to inform your team members and call for help. That is the first step you have to do. And with the help of the team, you have to perform various set of maneuvers, which I will be dividing and telling you as first line maneuvers and second line maneuvers. Because a prompt delivery in attempting the various maneuvers will help in reducing the fetal injuries, fetal morbidity, mortality, as well as it is very important to reduce the maternal injuries also, right? Okay. Now we will see what are the various line of maneuvers we have. Okay. So, if we have first line maneuvers and second line maneuvers. Okay. So, first line maneuvers include macrosomia maneuver, along with suprapubic pressure. Then the second line maneuvers include Rubin's maneuver or Wood's corkscrew maneuver. Clear? See, we have two lines of maneuvers as I said. So, first line maneuvers include macrosomia along with suprapubic pressure. Second line maneuvers include Rubin's maneuver, Wood's corkscrew maneuver. Clear? So, there is a maneuver for delivery of the posterior arm. You can also do a casket maneuver, and there are some maneuvers for posterior sling axillary traction. Okay, posterior axillary traction, that includes Mentico claw maneuver or posterior axillary sling traction maneuver. Okay. And other than that, we have some heroic measures maneuvers which can be attempted as a last resort. Okay. So, these includes intentional clavicular fracture, Zanavelli maneuver, abdominal rescue, and symphysiotomy. Okay. So, this is very important. So, once again we will revise. The first line maneuvers include macrosomia maneuver along with suprapubic pressure. Second line maneuvers includes your Rubin's maneuver, Woodcock's maneuver, delivery of the posterior arm will be performing maneuver, and for casket maneuver. Posterior axillary traction means we will be using Mentico maneuver or posterior sling traction maneuver, and heroic maneuvers include intentional clavicular fracture, Zanavelli maneuver, abdominal rescue, and then symphysiotomy. Okay. Now, if you see this, this is the maneuver in which they are performing macrosomia maneuver. Okay. So, what is being done in this maneuver is that we are hyperflexing the maternal thighs over the maternal abdomen. Okay. So, while doing hyperflexion, what is going to happen is, see, there is symphysis pubis here. Okay. So, this symphysis pubis has moved on here and the position from here has changed to here. That means there is straightening of the lumbosacral vertebrae. Okay, and there is increase in some space also. And why the suprapubic pressure is necessary means, while giving suprapubic pressure, what you are going to do is, you are going to adduct the fetal shoulders. So, while you are doing adduction of the fetal shoulders, the fetal presenting diameter of the shoulders, that is the bisacromial diameter, is going to reduce. Okay, when it is reducing and when we are making more space by making the lumbosacral spine straight and hyperflexing the thighs of the mother, what is going to happen? Yes, you will have, the delivery can be made even more easier. Clear? Right. We will see macrosomia maneuver once again. So, macrosomia maneuver. This is the first maneuver that has to be performed in case of shoulder dystocia, and this has to be performed along with suprapubic pressure. So, we are going to hyperflex the thigh of the mother. Okay, hyperflex the thigh of the mother over her abdomen. Okay. So, this is going to straighten the sacrum on the lumbar spine. Okay. Then we are also going to give suprapubic pressure, right. So, suprapubic pressure decreases the bisacromial diameter, which is the engaging diameter of the shoulder. So, basically we are going to adduct the shoulders. Clear? Yes. Now, we will see the second line maneuvers. In second line maneuvers, the first two maneuvers what I have mentioned, that is Rubin's maneuver and Wood's corkscrew maneuver or rotational maneuvers. Okay. So, we will see what is Rubin's maneuver. In Rubin's maneuver, what we are going to do is, we are going to insert our hands into the vagina and we are going to get access to the posterior aspect of the most accessible shoulder in the vagina. Okay, and we are going to give a pressure such that the shoulder is being pressed towards the chest. See, they are leaving hands into the vagina and a pressure is being given such that the posterior shoulder is being pressed towards the chest. Now, what we are going to do is, we are going to rotate the baby, and as the rotation is complete, we are trying to deliver the anterior shoulder first, which will be impacted under the pubic symphysis before the rotation. Clear? So, this is Rubin's maneuver. So, I will explain it by writing so that you will understand it better. So, Rubin's maneuver is performed by placing a hand into the vagina and pressure is applied to the posterior aspect of the most accessible fetal shoulder. Okay, and this pressure should be applied towards the chest of the fetus or fetal chest. So, what is going to happen? There is adduction of fetal shoulder and the anterior shoulder, which is impacted under the pubic bone, is delivered. Right? So, this is Rubin's maneuver. So, this is Woods-Corkscrew maneuver. Okay. So, what we are going to do is just like how we do a screwing. Okay. Like that we are going to get access to the anterior aspect of the posterior shoulder of the fetus. Okay. And then you are just trying to rotate the fetus just like a screw. So, that you will be delivering the anterior shoulder first, followed by the posterior shoulder. Okay. So, this is Woods-Corkscrew maneuver. So, what you are going to do is hand on anterior aspect of posterior shoulder and rotated around even 180 degrees. Okay. So, this rotation will deliver the anterior shoulder followed by posterior shoulder. Clear? We can also make the delivery easier by attempting to deliver the posterior arm first. Okay. So, delivery of the posterior arm. See, as you see in the pic, what we have to do is, we have to get access to the posterior shoulder first. Okay. You will be crossing the posterior shoulder, you will be crossing the posterior arm, and then you will get access to the forearm. Either by holding the forearm or the wrist, you have to sweep it across the anterior fetal chest. Okay. So, first one, grasp the wrist with thumb or index finger, and then you have to try to flex the elbow, and then you will be sweeping the hand across the chest and you will be trying to attempt deliver. Okay. Suppose if this access is not possible, you can even give a tap on the antecubital fossa. So, it will be leading to flexion of the forearm. What is the advantage with this method is, normally we know that this acromial diameter is going to be the presenting diameter. But when you attempt to deliver the posterior shoulder first, what happens means the axilloacromial diameter becomes the presenting diameter, which is going to be 3 centimeter less. Okay. So, this is of great significance. So, that is why you can try to attempt the posterior shoulder first, right. Okay. Now, we will see the next maneuver, that is Caskin maneuver. See, this is the Caskin maneuver in which the patient is asked to go on all fours position. Okay. All four position. That means she is supporting on the legs and hands. Okay. After that, you will be trying to attempt either the delivery of the posterior arm or the delivery of the anterior arm, or even you can try a rotation of the posterior shoulder and try to deliver. Okay. So, this is Gaskin maneuver, right. Okay. Now, we also have some posterior axillary traction techniques. Okay. So, what is this posterior axillary traction techniques? So, these are special techniques that are done when the fetal arms are extended. So, there are two methods, namely Mentico-Glove method or maneuver, and then posterior axillary sling traction method. Okay. So, while doing both these maneuvers, you should have an assistant nearby who will be flexing the fetal head and lifting it upwards towards the anterior shoulder, right. Okay. Now, we will see the Mentico-Glove method. So, here what they have done is, they have clasped both the fingers in the posterior shoulder of the fetus. See, they have clasped the middle fingers especially. Okay, and using or hands as a traction, will be trying to deliver the posterior shoulder just by pulling it out, right. So, that is Mentico-Glove maneuver. So, Mentico-Glove maneuver, where the middle fingers are placed under the fetal axilla and applied a downward and outward traction. Okay. So, just like pulling the posterior shoulder out. Okay. So, that is Mentico-Glove maneuver, and this will lead to the delivery of the posterior shoulder first, which will be followed by delivery of the anterior shoulder. Okay. Yes. Now, just like the Mentico-Claw method, we will be using posterior axillary sling traction. Okay. So, what is the sling? Sling may consist of a suction catheter or a firm urinary catheter. Okay. So, just like this. Okay. What you will be doing is you will be using a catheter and you will be holding the posterior shoulder, and then you will be trying to deliver the posterior shoulder first by giving an outward traction, and then you will be delivering the anterior shoulder. Okay. Next we will see some heroic measures as we have discussed. One is intentional clavicular fracture. See here, the fetal clavicle has to be fractured, that is the anterior clavicle should be intentionally pulled outward and it should be fractured. Okay. So, this will reduce the diameter of the presenting shoulders and then you will be able to deliver the baby. Okay. But there are some complications like one, there can be possibility of injury to the vascular structures. Sometimes the bone may go inside, right. So, even the pulmonary damage can also be there. Clear? Right. The second maneuver is Zanaveli maneuver. See, what we are going to do in Zanaveli maneuvers means the fetal head has to be rotated towards a pre-restitution position and you will be pushing the fetal head into the vagina. Okay, you will be just replacing the fetal head inside the mother itself. Then you will be shifting the mother to the operation theatre and you will be doing a cesarean section. Okay, so that is Zanaveli maneuver. So, fetal head rotated towards pre-restitution attitude, pushed into the vagina and back into the uterus. Okay, and this will be followed by a cesarean section. Another method we have is abdominal rescue method. So, abdominal rescue method is performed when Zanaveli maneuver is not successful. What you will be doing is, you will be doing a low transverse incision hysterotomy alone. Okay, then you will be trying to manually rotate the fetus into an oblique diameter. Okay, you have to bring the fetal shoulders into an oblique diameter by manually rotating through the transabdominal incision you have given for hysterotomy. Then you will be trying to deliver the baby vaginally. Okay, so it is done when Zanaveli maneuver is not successful. So, we will be performing a low transverse hysterotomy and the baby is manually rotated into an oblique diameter through the transabdominal incision. Okay. Now, after this, we will be trying a vaginal delivery. Okay. Yes. And the last method is symphysiotomy. See, in symphysiotomy, what we are going to do is, we will be keeping the patient in lithotomy position, we will be using a Foley's catheter to drain the bladder and then we will be retracting the catheter aside and keep. Now, you have to start incising the pubis starting from the skin subcutaneous tissue and even the anterior fibers of the pubic bone has to be incised. Okay, so that is symphysiotomy. So, this will be making up some of the space and then you can deliver the baby, right. So, that is symphysiotomy. So, first the patient should be in lithotomy position. We will be placing a Foley's catheter and urine drained, then the catheter is retracted laterally, skin, subcutaneous tissue or incised with the scalpel, okay, till anterior fiber of pubic symphysis. Okay. See, this is only attempted, this has to be attempted only as a last resort when all the other maneuvers have failed. Clear? Right. So, generally, what are the complications you can expect with shoulder dystocia? So, complications that are expected with shoulder dystocia may include obstetrical brachial neuropathies, okay, obstetric brachial, repeating. So, let us see the complications that are associated with shoulder dystocia. Complications may include obstetric brachial plexopathies, okay. So, the incidence rate is around 3 to 17%. You can have the upper lesions or even lower lesions. So, upper lesions means around C5, C6, this will be leading to Erb's palsy, and lower lesions means C8, T1 cords are affected and this will be leading to Klumpke's palsy. Yes, and there are chances of phrenic nerve palsy also. Sometimes that can even present as Horner syndrome. There can be chances of clavicular fracture, humerus fracture, and permanent brachial plexus palsy can be seen in around 0.5 to 1.6% cases. And then there can be chances of hypoxic ischemic encephalopathy as well as death, that is seen in 0 to 0.35%. Hypoxic ischemic encephalopathy is also seen in 0.3% of the cases. Clear? So, I hope you would have understood what is shoulder dystocia, what is turtle sign, what are the complications leading to, and what are the complications that arise from shoulder dystocia, as well as the various maneuvers that will be performing if shoulder dystocia occurs, right? So, with this we will be completing this topic. Until we meet in the next topic, take care, happy learning, and bye bye.